Full watch. Oh, right. We are... If you're just joining us, welcome to the Monday Report. This night we're discussing diabetes and well-being. We've taken a round of questions from our audience because this is a town hall. But if you're just joining us, we have with us Dr. Catherine Karekezi, Executive Director, Non-Communicable Diseases Alliance of Kenya, Dr. Rosaline Ngugi, who is the Chair, Kenya Diabetes Study Group. She is Vice-Chaired by Dr. Rilwan Aidan Mohammed. And we also have with us a pediatric endocrinologist, and she's also chair of the Pediatric Endocrine Society of Kenya, Dr. Phoebe Wamawa. So we left off on the question of pregnancy, what happens if you have diabetes and how that impacts delivery and also the pregnancy. And you really provided a lot of information on that, but there was also a big issue of awareness. Dr. Karekezi, questions around in the community, why is there not more awareness and also stigma where children who suffer from type 1 diabetes are concerned?
Okay, a bit of a difficult question, but in terms of awareness, there are different things that different organizations are doing. Maybe like working through churches and community groups, working with people with lived experience of diabetes who can educate the community about diabetes. And especially now when we come to children, I think traditionally diabetes was seen as a condition of older persons, people in their retirement, heading on, and many people do not understand that children can actually have diabetes, type 1 diabetes. So it's something new in the community. And essentially, because of the lack of awareness, especially in schools, these children tend to be stigmatized by the other children. In some cases, they're also stigmatized by the teachers and the administration, which should not happen. And also what tends to happen for, especially when they get to high school, many boarding schools may refuse to take the children on board because they don't know what to do. They are not aware of how to manage type 1 diabetes. But just to mention that all is not lost, various organizations have been working with religious groups and community leaders to spread the message about diabetes in the community. For example, Kenya Diabetes Management and Information Center has been going into schools to teach teachers and also children about type 1 diabetes, what it's all about, and how to help children living with type 1 diabetes in their schools. Primarily, they go into schools where they already know that there are children living with diabetes in those schools, so at least the school knows how to manage, how to assist. But again, just creating general awareness about what diabetes is. Diabetes is a lifelong condition, yes. It's a condition that you do not catch from somebody else. So I cannot transmit diabetes you cannot catch diabetes from me, let's say that. So essentially, it's not like HIV/AIDS or malaria or TB, which you catch from the community. So essentially, one should not be worried about a child getting diabetes from another child. So, but this is things that we need to really create awareness in the community, create awareness in the schools, use religious organizations, use community leaders to spread the message of diabetes in the community. Of course, now we have the community health promoters who are now on board, and they're also being educated about what diabetes is all about. So I believe that in the near future, there'll be a lot more awareness about what diabetes is, how you can manage it, how you can, the risk factors for diabetes, especially for type 2 diabetes. Certain things will make you more likely to have type 2 diabetes. And if you do have diabetes, what should you do? So diabetes is not a death sentence. One can learn how to manage and live a productive life and contribute to the economy. But one needs to be assisted in order to do that, to learn about it, to learn how to manage. And because it's a lifelong condition, one really needs to know how to manage the condition for themselves and when they need to seek help and all those other things that go with living with diabetes as a chronic condition. Yeah.
Okay. I know we've addressed stigma, children with type 1 diabetes, but Dr. Malwa, are we seeing more and more cases of children with type 2? Is that something we should be concerned about?
In time to, of course, with the increasing sedentary lifestyle and change in the diet, we are having a number of children developing obesity, overweight, and henceforth now developing insulin resistance. So we are increasingly getting children with type 2 diabetes. But just to add on what Dr. Karekezi said about diabetes in school, and I think there was a question on that and stigma. We try to empower these children and their caregivers that their rights as children is enshrined under the Constitution of Kenya, that these children have a right to health, they have a right to school, education. And again, the UN legal framework on children's rights is also has adopted that, and also the WHO. So it is a crime for any school to discriminate any child with type 1 diabetes or whatever type of diabetes on the basis of that condition, and they should be sued. However, whenever we make a diagnosis of this in these children, we prepare them, we prepare their caregivers, and give them a diabetes management plan. Fully written plan on what diabetes is, the child has been diagnosed, and of course what they need to be doing at school, and the child will go with it. And keep a copy, and the other copy, of course, is given to the class teacher. We recognize that some schools are not very well equipped in that they don't have school nurses, but we encourage them to share their condition with their class teachers. And also, there are some schools that do not have fridges, for instance, to store insulin. But we teach them that you can modify something that can act as a fridge so that you do not skip your insulin while at school. So we are working closely together with schools, and especially alongside our diabetes nurse educators. And as we are speaking, Pediatric Endocrine Society of Kenya is working on something to enhance diabetes in school so that we reduce the stigma and discrimination.
Okay. I have another question, just looking at some of the feedback that's coming in. I'm seeing here Samuel Orutwa says diabetes awareness, it's well said on mass media, but very hard to find places to be offered services on diabetes. If any, most of the people cannot afford but watch themselves get drained out for death. Access, I'm guessing, to healthcare is the issue he's raising. But before we get into the employment issue, and you know, when you're applying for a job, you'll fill out those forms, right? And they'll ask you, do you have a family history of these diseases? And then you have employers who are worried this person, they might not turn up for work. They will take many sick days. You know, they need a lot of care. Why? I don't need the headache. So before we get into employment policy and protections available, there's also the question around communities and awareness. I read that out of 3 in 4 people with diabetes in the world, they come from low and middle income countries. Why is that? Because if type 2 diabetes is identified as a lifestyle disease, do you want to take that one, Dr. Ngugi or Dr. Aidan? Dr. Ngugi, do you want to take that one?
We'll share. We'll work together. We work very well together. So it's interesting. Initially, it was called a lifestyle disease in developed countries. But as we go along, what are we doing? The children are on the iPads and not actually running around. Now, the problem with the low and middle income countries is that you find it's actually cheaper to buy, say, you call it chips. Yes, that one, chips muitu. Have you tried it? It's very tasty. But then, if you actually go and buy a bunch of skuma wiki, it's actually more expensive. And then remember, that is raw. You still have to fry it, and then you still have to go and buy the flour to make the ugali, so which is cheaper. So we're finding that there's a lot of junk food. And one of the things I'm so glad to hear PESC talking about is what are we educating our children? You know, we've grown up eating junk, and then we end up thinking this is how we show love to our children, by giving them junk. So now schools, we should change the narrative and say you should have fields where the children can run around. If you're going to carry a snack, carry an apple, carry a carrot, carry a cucumber. Just carry snacks that are healthy.
But you know, when you're walking through town and then that harufu hits
you. Do you realize that when you're walking through town, you'll find most of the fast food restaurants have mirrors on the side? Do you know why they do that? Because the minute that you look at that mirror, what do you see? It looks so enticing, and then with the smell wafting through, that's why the doors are always open. You're tempted to go in. But you think about it, it's true, isn't it? Yes. I'm sure a number of times you found yourself going to one of those joints. I won't mention them. But the concept is we're eating more and more unhealthy because of food insecurity. It's so expensive to buy the basic things like vegetables. I can't even afford to, so I'm opting for, if I can get a small patch, then I'll be able to grow my tomatoes and my vegetables. But even then, I still have to buy the oil, water that has to be purified. So when you think about it, you find them eating more junk food, and then you're constantly working just to try and maintain a lifestyle that you want, just to be able to survive. So when do people exercise? And that is why it is catching up with us. You wake up, you go to work, you come back, you eat, you sleep. You're eating at 10 p.m. and you're going to sleep at 11, only to wake up 4 hours later. We say you need to be healthy. Do you know that if you sleep less than 6 to 7 hours, it increases your risk of developing diabetes?
No, I did not know that.
So everything is linked. And that is why we are slowly catching up and surpassing. And the projections are by 2045, there'll be 156% increase in the rise of diabetes. I'll let Dr. Rilwan tell the rest.
Yeah, because that's in Africa. 156% increment is in Africa. The highest increment expected by 2045, according to the International Diabetes Federation. I think she forgot to say sitting is the new smoking. So we are always sitting, so the risk is, so probably I should stand up. I think another risk that increases the diabetes burden in the low and middle income countries is the genetic makeup. So African, Black African and South Asian population tend to have more genetic preponderance to developing diabetes as compared to the Caucasians. So our genetic makeup already predisposes us as Black population to developing diabetes. But again, there are those who do not have genetic predisposition. But she mentioned something very important about the vicious cycle. So now we have what we call epigenetics. The environment is changing your genes. We have patients coming in and saying, there's no history of diabetes in my family. I'm the first one. You're the first one because the environment which has been created by probably the mother who's had probably so many sodas, that child, genetics have been changed. That child will develop diabetes.
What?
And from there it develops onwards. So now the epigenetics comes in. So that's why now I think the metabolic and non-communicable disease world is talking about the concept of life course approach in terms of preventing diabetes. It's a life course throughout, from utero, from when you're pregnant up to onwards, that's when the prevention starts, not from the time the child is going to school. So those are the things that are predisposing our continent more to diabetes. And then obviously again, awareness. Somebody has mentioned about awareness. People are not aware of their healthy lifestyle, so that is the health literacy levels is a bit lower on this aspect, on this part of the world as compared to the Western world.
Okay. So before we take another round of questions, there's one which was pending on employment asked by Duncan. Are you able to take that one, Dr. Kari?
About being discriminated against because you have diabetes?
Yes.
I mean, essentially it shouldn't be the case because it's your right and to be employed. So I believe it's just like having HIV/AIDS. You should not be discriminated against because you have HIV/AIDS. So whether or not you're going to be absent from work or not, that should not be a reason for one to be not to be employed.
Okay, Doctor?
The times have changed, and what we are having now is you'll find most of these conglomerates, actually big companies, actually have a nurse or a doctor who then is able to manage. So one of the things we always insist, yes, you can be discriminated, but it's worse to actually lie about not having a condition until you actually do get a complication and you're admitted, and then you say, yes, at the time I didn't want to disclose. So one important thing, the only way we can raise awareness is be honest. Do not hide it from your application. Then number two, as KDSG, what we do now is we're raising awareness by capacity building. We're training those nurses and the doctors who are in various companies. Like I will work with a company and I'll come and give trainings on diabetes, on hypertension, on cancer, such non-communicable diseases, so that they're aware. and then they can be able to then now send to us as complications arise. That's one very important thing. I can give you an example, like pilots. Would you be comfortable if your pilot is flying and has diabetes? Simple answer is yes. As long as he's managing his diabetes, he's like you and I. And it's nowhere it's written that you have diabetes. The concept is, in fact, if anything, you're more aware of your current state and you make sure you feed well and all. So we find those people who have diabetes influence people within the company positively, because they're eating healthy, and they actually now have that good support group if you have others who have diabetes. But ideally, what Dr. Karekezi said, they should not be discriminated. It's actually against the law. And what we're doing now is working with other corporates to start the trainings, such that if you have, and we ask you simple questions, do you have a relative who has diabetes? Why don't we screen? So we're finding a lot of people who have their annual company screen, and we really have to thank private insurances for this. When you go and apply for your job, when you're applying for your job here, I'm sure they made you go and do an annual checkup, right?
Yeah.
And they do that annually. Now that then guides you and says, we have a red flag, you're pre-diabetes or you're diabetic, then come and see Dr. Ngugi and continue. So that's how we are now picking up, and people shouldn't be afraid of that.
All right.
Yeah.
Just one more point to add on that is not to discriminate, but when patients start developing complications, depending on their nature of work, the occupational health specialist should be able to change this person's. I'll give you an example. We have patients who have complications of the eye. So they cannot see well because of diabetes. And by the way, every patient with diabetes should have their eyes checked, whether they have eye symptoms or they don't have eye symptoms, once a year. So every year they should have their eyes checked. But now come to those who've developed complications of the eye, and so they have retinopathy, they're bleeding inside the eye and they cannot see well. And his job is driving. So this patient who cannot see well is a hazard to himself and to other drivers on the road. So we advise them, if you're not seeing well, please do not drive. So you have to have your eyes checked and have that sorted. And then we have these patients who are on multiple daily injections of insulin, who have high risk of going into hypoglycemia, that is very low blood sugar levels. And these patients have a high risk of losing consciousness. And if they're behind the wheel, they are a risk too, and their job is driving. So we ask them if they could, in their company, probably be transferred to another, probably a desk job as opposed to. So these are the complicated patients, but diabetes, well controlled, should not be a cause of not being discriminated. But even those with complications should not be discriminated, but be assigned other duties probably in the company, as opposed to those, especially those who work with fine machinery, and they can probably lose consciousness because of the low sugars, or they get dizziness because of diabetes. Can sometimes cause dizziness as well as a result of the nerve complications, the autonomic dysfunction. So these are the caveats that you should have.
All right. So we'll take another round of questions. We'll take 3 from here and 3 from this side. So the gentleman holding the mic, you can ask your question, then pass it to the lady who's right behind you. We'll start there.
Thank you. My name is Silas David. I chair the Parents Association of Kenya. I'm the National Chairman of the Parents Association. We talked about 2.3 million Kenyans undergoing through diabetes infection. Out of this, what roughly is the number of children that are suffer from diabetes out of the 2.3 million? Do you have some rough figure about that? Secondly, age and gender, do they also have any kind of connection with the diabetes? Finally, as a comment, I chair the Parents Association. Parents are not informed. That's why children in schools are suffering. So we ought to have gone down. When you talk about the community, whom are we talking about? We should be talking about having reached parents. If we reach parents, then we shall reach the children. When we reach schools, we are reaching the children. There's discrimination in schools because there's lack of disclosure of information to the teachers. So they don't know. They will see a child who is just fainting and they think that this child didn't take breakfast. And yet there's that issue. So we require to have information on the ground.
Okay.
Thank you very much.
Remind me your name, sorry?
Silas David. I chair the Parents Association of Kenya.
All right, thank you very much for your contribution. You can pass, yes, to the young lady behind you.
Hello, everyone.
Hi.
I'm Dolphin Mokeira. I'm a special needs teacher. I deal with kids with hearing impairment. So my concern is on awareness. These kids, I don't know if right now we have an interpreter down there on Citizen TV.
Yes, we do. Her name is Njoki Chege.
Okay, that is very nice. Most of the time it is easier said than done. So I will want to say that these kids really go through a lot of, I can say, problems. These kids who have hearing impairment, and they really go through stigmatization in school. Let's say, sometimes when you find the other students seeing this one doing injections, they think that maybe this one is doing drugs or something, but this kid is just doing it because it's a medication. But the other one doesn't understand that it's a medication, they take it as a drug.
Okay.
Get it? So
you're saying awareness is critical?
Yeah, awareness is very critical.
All right. So pass the mic behind you. There's a gentleman at the far end. Naona sitaki kumdiscriminate pia yeye juu ya distance. Pass the last guy in the glasses. There you go.
Thank you. I'm Lucas Owaga, and I'm a student from JKUAT. So my question will be directed to Dr. Karekezi. Dr. Wamalwa has talked about the insurance scheme only catering for a yearly checkup for the HbA1c. So as the chair of NCDA Kenya, are we on the table during discussions of packages for the insurance schemes? Since we are acknowledging private sector and private companies for the same, but what percentage of Kenya is under the private sector? Most of us are only able to take care of ourselves using the public insurance schemes. So are we on the table championing for diabetes and other non-communicable diseases to be included in the insurance policies? Thank you.
Very, very good question, Lucas. We'll take a couple of questions from here. There's the gentleman. I don't know who has the mic. You can pass it to the gentleman to your left.
Before I hand it over.
Sorry? Yeah, just pass it. You also had a question?
Yes.
Okay, ask it quickly and then you can pass it.
My name is Cyprian Kipkuru, a member from Young and Sweet Diabetes Support Group. My question is, recently we've seen a very sharp increase in patients or kids with type 1 diabetes. Can we really get to know what causes this type 1 diabetes in young kids? And again, secondly, when you go to hospital, you are asked if you have a relative who has or had type 1 diabetes. And on the other side, you're told type 1 diabetes is non-hereditary. Now, my question is, why do they think because you have diabetes, you have it because you had a relative who had it?
I was asking myself the same question. You can pass it to the gentleman. There we go.
Hi.
Hi.
My name is Joseph Karanja Kamau. I come from Mathare slum areas. And there's a big problem in Mathare because many people are poor, and you'll find there's discrimination because in the slum areas, mimi nilikuwa nataka kuuliza, kuna uwezekano kuwe na special squad ambayo itakuwa ikishughulikia watu wa sukari, kwa sababu kama vile kulikuwa na mgomo ule ulipita, watu wa sukari waliumia sana. Kwa sababu leo iwe ni siku yako ya kwenda kuwa checked, alafu unaambiwa madaktari wamegoma na sukari imepanda, wewe huwezi kuicontrol. Ukijaribu kukunywa hizi glucomen inakuwa ni shida sana. Especially mimi nilipata shida sana kwa sababu sukari iko juu, na nikifika kwa daktari ananiambia tumegoma, you come next time, na bado sukari iko juu. Saa ingine inaenda chini kabisa. Kuicontrol ipande and you are not a doctor is a big problem. So sijui kama munaweza kulilia serikali iwe na kikosi maalum ambaye akiwezi kugoma, kwa sababu mtu
Joseph, I think tumelewa swali. We just take one more. There's a lady right in front of you, Joseph. Pitisha hapo tu.
Hello, everyone. My name is Josephine from Young and Sweet. I'm a type 1. So I think there's a problem when it comes to standardization of information in treatment of type 1 diabetes. Don't think whatever we have been told in Nairobi County is the same information they receive in Turkana. So I guess there is a gap that we need to bridge. So
it appears the question's on training, right?
But let her deal with all the type 1s.
Okay.
Then our mandate for KDSD's training, we'll talk about it.
All right. So so the first contribution we got was from Silas. I hope. Silas. So he was giving recommendations where children are concerned, and we also had Dolphine who was making the same recommendation. Let's start with this question that was asked by Lucas, and we'll start with you, Dr. Karekezi. Are you on the table when these packages, public packages, are being formulated?
Okay, let me say we have asked to be on the table. We have protested as to what has been going on, and we have made our voices heard because people living with different conditions have been left out. People are not able to access treatment and care, and even the packages which have been developed so far are really not going to contribute. Okay. They're insufficient, let me put it that way. You cannot say that a person living with diabetes is going to have an annual cover of 6,000 shillings in a year. That may cover maybe 2 consultations, will not cover your HbA1c, cannot cover your glucose strips that you need to monitor your sugar, and even the medicines. So really we need to go back and reevaluate the packages which have been proposed because they're not realistic, to tell you the truth. And I know we have had discussions as NCD Alliance with different partners. We have had discussions with patient groups. And last week we actually had a press release about the shortcomings of the Social Health Authority and the packages which have been developed, because at the moment they're really insufficient. And for people with lifelong conditions who need constant medication, who need routine monitoring, as we have said today, diabetes is about controlling your sugar. You take your medicine, you take your insulin, but you need to monitor your sugar levels on a regular basis. And it's only as you monitor those sugar levels and you know how your sugar control is that you'll be able, the doctor will be able to advise you, do I need to change the medicine? Because if you're living with elevated sugars for a long period of time, as you have heard this evening, it's going to damage multiple systems in your body, your eyes, your nerves, your kidneys, your heart, and many things. And this is going to lead to these long-term complications, kidney failure. You may have an amputation, you may go blind, you may have a heart attack, you'll have a stroke. So really, monitoring of diabetes is key. The blood glucose strips are key. The HbA1c, which you should at least do, if at all, ideally 3 months.
What is HB?
HbA1c is a test which tells you the average blood glucose levels over a 3 months period, because your red blood cells have a lifespan of about 3 months. So this is a very good test which actually shows you what has been your sugar control over that 3 months period for the lifespan of that set of red blood cells. So it's like, it's what globally is being used to monitor blood sugar control. Yes, you can do your daily blood sugar tests, but you'll have a lot of fluctuations. But this HbA1c will give you what has been the average blood sugar over that 3 months. And it's a very good indication for the doctors to be able to adjust your treatment. But at the moment, most programs at the moment will only allow you to do like every 6 months, which is better than none at all. So, but then again, ideally you should be able to do it more frequently. Ideally you should be able to monitor not just your sugar levels. You should have a kidney test to see are your kidneys still functioning well. As Dr. Wamalo has said, you need an eye test at least once a year. And you need regular tests to just monitor the electrolytes in your system, just to make sure that all the body is functioning well. As you've heard, diabetes, uncontrolled sugars will damage your kidneys, will damage your nerves, will damage your eyes, will damage multiple organ systems in the body. And that is why it's very important for us to create awareness of what diabetes is all about, and why it is important for us and for everybody to be able to monitor their sugar, to try and prevent these complications which compromise your body system. Yeah.
All right. So Silas raised a point, and he said we are talking about this 2.3 million. But what is a percentage where children are concerned, which also raises the questions on research and data in this area. But before you get to the questions around type 1 diabetes and standardization of care, perhaps you could address that one?
Thank you, Silas. Type 1 diabetes globally is thought to be around 5 to 10% of the entire diabetes spectrum. Now, come to Kenya. We do not have confirmed data, but observationally, the children and adolescents who are under our care are just above 5,000. But now when you look at the International Diabetes Federation figures, the modeling study that they did, they're saying that the incidence, the prevalence of type 1 diabetes is rising and rising rapidly, especially in the sub-Saharan region. So whereas it used to be 5 children in 100,000 people in the population developing type 1 diabetes, right now it has actually gone 4 times higher. We are talking of 20 per 100,000. Now come back home. If we cascade that down to our 0 to 19 years old, then we should be talking of slightly above 100,000 children and adolescents with type 1 diabetes. Then the question on standardization of management. Yes, that's a very good point. For the last 8 months, as Pediatric Endocrine Society, we have traversed the entire nation. We went to Turkana, we went to Mandera, and we trained for 7 counties. And in every county, we took a multidisciplinary team of at least a pediatrician, a medical officer, a clinician, a psychologist, a nutritionist, a diabetes nurse educator, and a pharmacist. And why were we doing that? We were basically bringing down the guidelines that were launched in June down to them. And what do the guidelines say about management of type 1 diabetes in children and adolescents? We are moving from the pre-mixed insulin, or whatever we used to call Mixtard or Novomix, to what we call basal bolus. That is multiple now daily injections of insulin. So every child and adolescent and young adult in Kenya with type 1 diabetes, they need to be at least on 4 daily injections of insulin. So of course, besides training, we are going down to mentor them so that the information gets cascaded down. The other problem could be just access to the regimen that we have recommended. But the Ministry of Health recently released a policy document to the Council of Governors instructing them that the drug of choice management of type 1 diabetes is by basal bolus. And they instructed them to ensure that those resources have been put in place in various pharmacies. So we are not yet there, but very soon we are going to standardize that. There was also a question on inheritance, the question that they normally ask if you have type 1 diabetes, or what are they asking about? Yeah. Is there somebody in the family with type 1 diabetes? So inheritance is there, but it's not as common as type 2 diabetes. So the chance of somebody developing type 1 diabetes, if a relative, a father or a mother has type 1 diabetes, is basically between 4 to 10%. Why is that? It's because everyone is born with special markers on some cells, and these markers normally tend to warn the body that we have an intruder in form of either a virus or a bacteria that is coming, and so you have to fight this virus. But there's some children who have unique markers that instruct the body that beyond destroying the virus, the cells now start doing what? Destroying themselves. And some of the cells that destroy themselves are the pancreatic beta cell that produce insulin. So it's out of that special markers. So you will find that, and then I think your next question was, why are we having an increasing incidence rates of type 1 diabetes? We really don't know. It could be perhaps the change in the ecosystem, the viruses around, but again, increase in awareness, where parents are picking out classical symptoms of diabetes, and healthcare workers are also picking out diabetes early enough before these children die, could be contributing to the rising incidence.
All right. Yeah. Dr. Aidan, perhaps you can take the question that Joseph raised on specialized care. You were saying, why do we not have these specialized healthcare workers in our communities?
I wish we did. At least I can't talk for at least national government level, but where I work at Lions Diabetes Center. It's a charity-based hospital. So our cost is a bit subsidized in the sense that it's not at the private care level. And so probably sometimes when you're stuck, probably you could come to us and we could see how we could help. But I think this is a systematic level, health system issue that probably needs to be tackled at the policy level in terms of not just during strike, but also probably availability of the medication, even if the patients, even if the doctors are not there, at least the continuity of therapy should be there. So even if it's the utilization of the community health promoters to be able to have these patients get their medication, I think that is key, because especially patients who require insulin, this could cause death within a few days if they don't receive it, especially like for the type 1 diabetes, they could go into coma. And for patients like him can develop complications quite easily. So to prevent this, probably we could utilize other form of probably health cadres that we could there. But again, to say we have in our center tried to utilize leverage technology in the sense of telemedicine and telemonitoring from just talking to the patients from wherever they are. I think everybody at this point has some sort of smartphone, or if possible, to the nearest pharmacy and being able to access. So probably we could utilize that kind of system where a person is able to reach a healthcare professional. So we have systems where we could monitor the blood sugars from where they are, wherever we are for our patients. That is, if they're using the apps that utilize this. So we can see the sugars and we can see the patient's information and we can talk to them and we can be able to tell them, so you can change this, go get this prescription from the nearest pharmacy. So I think leveraging technology in our setup is key, because the kind of capacity that we are working with, especially for us, the access to health professionals who are specialists in our country is mainly in the big cities. So as for me, I have a lot of patients who come from out of Nairobi. And some of them are elderly, so we have this platform which has at least helped us gain access. It's picking up slowly, very slowly, but I think as we speak about it, I think we could get there. So utilizing other forms could be a solution to this.
All right. Yes, please, Dr. Karekezi.
I think one of the things that our communities can do is starting support groups, like self-help groups. If you have an individual who is a bit more knowledgeable about diabetes, just coming together and sharing your experiences. I know there are certain groups in different centers, like there's a one in Westlands, where they're able to start like even a small revolving fund. So you contribute money amongst yourselves, and you're able to buy medicines for each other. Obviously, we know, yes, the government should be supporting, but we really need to look at how can we also help ourselves. So forming those kinds of support groups, maybe working with a nurse educator or a community health worker who's knowledgeable about diabetes, or inviting another group that is already set up, just to kind of show you what you can do to at least support yourselves, even as you wait for the doctor strike and other things to work themselves out, and also reach out to such groups. So I think that is something that communities can try and do, and reach out to different type NGOs who can come in and at least help you, educate you on what you can do and how you can manage your conditions as best as we can. I know it was a big problem during COVID because clinics were closed and people were not able to access treatment and care. But by having those small groups and helping each other, so long as you have somebody who's knowledgeable about the condition, that should really help. And also now with the community health community health promoters who are slowly being educated and trained about diabetes, I think this will be something which in the course of time will resolve itself. I know probably not soon enough, but there is a way in which people can come together and try and see how they can support themselves. Maybe I can...
Sorry, you had something to add?
No, I know there's somebody here who can actually support that kind of system.
Oh, do you want to call them out? They can
Beva?
Speak to that.
Can you speak to that? About support groups?
Okay, who has the microphone? You need the microphone. It's coming all the way from the back. So we'll take just 2 more contributions from here and from here, and then I'll invite you to make, to make your final remarks. So you can go ahead. Is the microphone on? There we go.
My name is Florence Kamau. Just as Dr. Karekesi has said, support groups, they really work. I'm the chairperson of the support group in Westland Health Center. And we didn't have any problem during COVID. We really took care of our members. We have that revolving pharmacy. We have a community pharmacy guided by the health center, and it is working. We take care of ourselves. We don't lack medication, treatment, with the help of the healthcare workers at Westlands. So even as we wait for government to support us, it is us who are needy. What is it that we can do about ourselves?
Okay.
Thank you.
Thank you very much. So I'll give you a minute each. So just one from here. There's the lady in the back. Okay, umesema ndo umeshikilia mic, sawa. Introduce yourself.
Okay, good evening. My name's Jenna Kinyi. I'm happy the madam has tackled about poor healthcare infrastructure. This is due to poor problem of governance, which we should check on that. Then my question goes on impact of global policies on local governance. How does Kenyan government align the health policies with global standards and best practices for diabetes management, care, and treatment?
All right, so I'm guessing Dr. Ngugi, Dr. Karekezi, either of you can take that one. Okay, one final one. Oh, ladies have taken over this forum. It's good. Yes, proceed, my dear.
Good evening.
Good evening.
My name is Christine Malawi, a member of the Young and Sweet. So mine
a member of?
Young and Sweet.
Oh, okay.
Yeah. So mine is about DKA. I've not heard anything about DKA. So it was just, I just wanted to say, what if I skip my insulin for maybe 2 days? Maybe I didn't have it, so I skipped for 2 days. Then for that 2 days, I also not engage in eating a lot, just taking lots of water, maybe exercise. What can happen, or can I get into DKA if I don't have my insulin for maybe 2 days? Yeah.
Sorry, did you say Christine?
Yeah, Christine Malawi.
What is DKA?
DKA
is okay.
Yes.
Diabetic ketoacidosis.
Yeah.
All right. So do you want to kick us off, Dr.
I want to just take you back a few steps back.
Right. So as you respond to these questions, we'll make our final remarks.
Yes.
Okay.
I'll be brief. Just a quick one. You know, as of 8 years ago, we were only having about 8 endocrinologists. We have adult, and basically we deal with diabetes and other hormones. And now we are at 30. Is that enough for a population of 52 million? No. So my message to you first is that as Kenya Diabetes Study Group, our mandate is training. And what we are doing is going countrywide, and we are working with Ministry of Health. Like, we got a grant with the World Diabetes Federation. And what we are doing is going to 35 counties, and part of it is as we screen, we train the healthcare professionals. So my plea to all of you, you all can't come and see Dr. Eden, Dr. Phoebe, Dr. Karekezi, Dr. Ngugi. Trust and believe that we are working at Kenya Diabetes Study Group with the relevant stakeholders to train healthcare professionals on what is latest, and that's why as we release the guidelines, that goes towards policy. We work with the relevant stakeholders to come up with Kenyan guidelines on the management of diabetes. If you look at that, it was management for type 1 and type 2 diabetes. Now, once you've got that manual, likely a healthcare professional will throw it away. But what we are doing is taking it a step further and going to the various counties, all the counties, and then training. So whether you meet a clinical officer, a medical officer, or a nurse, we are going to train. We commit to train as Kenya Diabetes Study Group with PESC and NCDAC, that we're going to train the healthcare professionals. You come to see me when you have complicated diabetes, but trust and believe that the medical officer or the nurse or the clinical officer you meet in Mathare or Turkana or Garissa has adequate knowledge of how to, one, either prevent diabetes, screen for diabetes, or treat diabetes. When it's complicated, that is when you come and see the specialist. So you can see, I give an example. KU has 2 endocrinologists. We have 80 patients at any time. Can we see all of them? No. So if you come and you find a medical officer treating, it doesn't mean that your treatment is inferior. And that's what the mandate that we are doing now in the Ministry of Health, of going countrywide to training. And that goes now towards policy. What we've realized is we're still having a large number of complications in spite of having a wide array of drugs. So we're going back and we work with NCDAC, and there is advocacy. We teach you how to recognize you have symptoms of diabetes. We teach the doctor, healthcare professional, how to recognize diabetes and treat it. Okay. And we are done. So hashtag diabetes and well-being, please, on 14th of November, walk instead of taking a lift, instead of taking a matatu, and eat healthy.
And the diabetic ketoacidosis? Diabetic
ketoacidosis is a complication of diabetes, whereby, like we had mentioned, your body uses glucose as a fuel for source of energy. Now what happens is, if you have missed your insulin, your body then, you have all this glucose, but it can't be accessed by the cell. So it uses the next form, which is your fats. Problem is, when it's broken down, it's quite inefficient, produces waste products called ketone bodies, cross the barrier of your brain, you start getting confused, you vomit. And so what we advise is, when you start to feel unwell, come to hospital. Okay. Don't miss your dose of insulin. For a type 1 diabetic, insulin is key above all else. So don't miss your dose. You can reduce your dose, but don't stop your insulin. That is key.
All right. Dr. Karekezi, as you make your concluding remarks, the question of, is our national policy in line with global policy where diabetes management is concerned? I think that was Jane's question.
Yeah, thanks for the question. I would say that the Ministry of Health strives to keep up with global trends and global policies. So even with the current guidelines, these are actually modeled on the current global standards for diabetes management. Yes, the system may be lagging behind in terms of maybe some of the commodities and the drugs which are available, but this is a work in progress. But essentially, the Ministry of Health tries to keep up to date with global trends to ensure that we are moving and keeping up with what is happening in the globe. We may not be able to afford all the drugs that the other countries can afford, but there's a wide array of drugs which are available. And also there's an essential medicines list And this essential medicines list is regularly updated. It's just that we need to be sure that the list and what is available in the different health facilities is actually what is listed. They are aligned, so they're synchronized. Because I know there is a problem sometimes. The essential medicine list, it would indicate that drug X should be available at the health center, and it is not available at the health center. But this is a work in progress, and we hope that we'll eventually catch up. And the list and the health centers will be synchronized, and somebody will be able to go to a health center and get the diabetes medicine as is listed in the essential medicines list. But this is a work in progress, but essentially the ministry does try to keep up to date within the confines of the budget, because we don't have an elastic budget, as we all know. Thank you.
All right. Your concluding remarks?
Concluding remarks. Yes, we've had a lot of discussion about awareness about diabetes and awareness in the communities and across the board. But I think as we create this awareness of diabetes, we also need to talk about equitable access to treatment, to healthcare for all Kenyans, especially in terms of different non-communicable diseases, including NCDs. So this is something that NCD Alliance of Kenya is working towards. We do work with the Ministry of Health, and we invite citizens to come to us and tell us the challenges that you face, and we see how we can work together to try and resolve some of these challenges, or at least make the government aware of what challenges the citizens are facing in accessing healthcare. Thank you.
All right. Dr. Wamalwa, there is a point that was made by Jane referencing your remarks on equitable access. How do we bridge that gap? Because it was you who was talking about the 30 endocrinologists, and you were talking about specialists being found in urban areas. What does that mean for the rural population? Dr. Wamalwa, you can address that as you make your concluding remarks.
Yeah, that's a good question, and I want to talk on the pediatric endocrinology side. Way back before 2008, we only had just less than 4 pediatric endocrinologists in Kenya. And right now, as we are speaking, we have around 15 ped endos, and we have diabetes nurse educators, some who have completed, others are in training. And we have fellows who are in training as pediatric endocrinologists. And basically, these are efforts that are being made by various partners to ensure that even the unreached child, in Chuka right now, we have a pediatric endocrinologist. In Kajiado, I'm there. So the efforts have been made right from the PETCA program that was initiated in 2008. That is the Pediatric Endocrinology a Training for Africa program, and it trained not only Kenyans but also other pediatric endocrinologists Africa-wide. Then after that, into 2021, the program was moved to be under the University of Nairobi. So as we are speaking, we have a Ugandan fellow, we have a fellow from Ethiopia, and then we have 3 Kenyan fellows. We have a program in Tanzania that is called ADECA, that is Allied Healthcare whatever program for training diabetes nurse educators. And so far, we have trained a number, and we are hoping that this may actually be rolled out locally. But beyond that, as Dr. Rosie said, immense efforts have been made by Pediatric Endocrine Society of Kenya. At the end of August, we had trained over 1,000 healthcare workers, multidisciplinary team in every county. Those are level 4 and level 5 hospitals. And we are looking at how this can reach out to all the children in Mandera, in Garissa, and name all of them. And we hope that by doing this, we shall increase access to healthcare and therefore bridging the global inequities. Of course, global inequities touch on diverse areas. When you're talking about the insurance, the finances, the commodities, the infrastructure, just the inbuilt environment. But I believe together with various organizations, we shall be there. My closing remarks. you are our greatest advocates. We have been talking about awareness, and we have said that we are losing 65% of children who have not been diagnosed with type 1 diabetes. For children, they do not have the luxury of staying on to develop chronic complications. If you miss out that diagnosis for a child, you lose the child. So let's go back to our communities. Let's, for the media, for various partners, us as individuals, and utilize our social medias to just propagate 3 classical symptoms of diabetes. That is increased frequency of urination, increased thirst, and weight loss. If parents are able to pick out these 3, then it will make it so easy for us as healthcare workers to pick it up from there and continue management. Thank you.
All right, Dr. Aidan, as you make your concluding remarks, there's a gentleman by the name of Sam Gituku who is asking you to address the question of dietary restrictions for persons with diabetes.
Probably a question best suited for nutritionists, but I'm going to try. So depending on, so when we talk about diet for patients living with type 2 diabetes, it's also highly individualized. This is because the calories that a patient requires going through their day-to-day is different for everybody. So you'll have somebody who's a construction worker and somebody who has sedentary lifestyle, like probably just us sitting behind the table waiting for patients. So those are 2 requirements of energy for these 2 people. So the driver of high sugar levels is mainly carbohydrates, which are energy-giving foods. So the level of carbohydrates consumed by these 2 people, and this is predominantly in the type 2 diabetes patients who have weight-related issues. So the energy consumption for these 2 patients should be totally different, because this one is consuming a lot, this one is consuming almost nothing. So a lot of times, especially for our overweight obese patients, we tend to recommend the low carbohydrate diets, of course, in combination with their therapy. And for the patients who are overweight, obese, and have prediabetes, we tend to recommend this. But again, the low part of the carbs is dependent on the patient's energy output. Output. Oh. Yeah. So there are a lot of fat diets out there. I don't want to mention a lot, but studies have also recommended the Mediterranean diet, which I don't think it can be adopted in our setup because that is not really compatible with us, but it tends to not use a lot of carbs as well. So that is what we recommend for our patients. The keto diet, which a lot of people talk about, that is dependent on the type of medications we give, because there are some type of medications that we use and a patient goes on keto diet that they can become ill based on that. They can develop a ketoacidosis, which Roslyn was explaining earlier. So we tend to tell our patients before they try out any form of diets, they probably speak to us and our nutritionists in the clinic.
All right. Yeah. Your concluding remarks?
So my concluding remarks, I think we've spoken a lot about diabetes, but what I want to mention is generally, so we've always had the topic on infectious disease, and HIV, TB, malaria always has the limelight, always has funding when it comes to this sort of interventions that we tend to do. So in Kenya and in Africa, to be precise, we are at what we call an epidemiological transition, where we still have a high burden of infectious disease, but we have an equally increasing, very fast, high burden of non-communicable diseases. So we really need to manage this. So amongst the non-communicable diseases should equally be given priority at policy level, because this is what's going to apart from and they're not existing exclusively at this particular point, because we have our patients who live with HIV, who have TB, also having type 2 diabetes right now, and we're co-managing it. So they're not exclusive, and they're having all this at the same time. So this should actually be given equal attention at every level, from individual to policy level. And then the other important thing that I want to highlight is obesity. I think Doc here mentioned about children with obesity. It's not only children, it's adults. And so societally, it's good to be a bit big and not really skinny. I mean, in the African culture as such, but Now we know in science that obesity is a chronic condition on its own. So it's no longer a risk factor for diabetes or heart disease or kidney disease. It is a condition itself that we need to manage. So if you know you're obese, please see your doctor. Because if you have a high girth in terms of waist circumference, that is actually adiposity or fat tissue, which is actually a condition on its own that needs to be managed. And we need to raise awareness on obesity and overweight as much as we're creating the awareness on diabetes as well. Thank you.
All right. So it's a good note on which to conclude this conversation, but the conversation continues online because the World Diabetes Day is on Thursday. So hashtag World Diabetes Day, hashtag diabetes and well-being. You can tag us as well, hashtag the Monday Report at Obarrows at Citizen TV Kenya. I want to thank our audience tonight who've asked very important questions on this issue. Unfortunately, we could not take all your questions, but I hope we've covered as much ground as was possible in the time available to us. I also want to thank my panelists. I'll start with you, Dr. Roselyn Ngugi, who is the chair of the Kenya Diabetes Study Group. She is vice chaired by Dr. Rilwan Aidan Mohammed, and we've also had with us Dr. Catherine Karekezi, and she is the executive director of the Non-Communicable Diseases Alliance of Kenya, as well as a pediatric endocrinologist. You see how these words are now just rolling off my tongue. Dr. Phoebe Wamalwa, and she's also chair of the Pediatric Endocrine Society of Kenya. Thank you for your contribution online, and just by watching and discussing this in your home, I hope we've made a difference. Enjoy the rest of your evening. I've been your host, Olive Barrows. And our sign language interpreter, Dolphine, before I miss this point, is Njoki Shege. Good night.